In this lesson, we will be reviewing the most important aspects of systematic neurosonography. Central nervous system malformations are one of the most important malformations regarding congenital defects. First of all, affect the survival of the newborn. The majority of the defects are severe lesions, are considered the second cause of infant disability. They cause not only alterations in the physical appearance, but in the disability degree, and as a result, less or more social integration and autonomy. The estimated incidence is unknown, because some of them start to show symptoms some years after birth, even in the adolescents, but it is considered that it shouldn't be inferior to 1%. It is important to mention that although the detection rate of the major malformations is high, it is considered that the detection of all the central nervous system alterations before the 22 weeks is low. One of its characteristics is its unknown ethiopathogenic origin. Its origin is multifactorial. Several of them have the same consequences and same characteristics regardless of the cause. These are difficulties that are seen in the interpretation of the ultrasound and diagnosis of the diseases. These defects can affect not only the motor part but the cognitive part as well. We do not always see both of them. We can see alteration that only affects the motor part or the cognitive part. In order to organize the detection, it is considered that in the prenatal stage there should be two levels of assessment. One that is offered to all the population. The axial planes are the ones assessed under basic biometries. Its objective is to detect anomalies and to confirm normality. Once an anomaly is detected, a neurosonography is indicated, where a multidisciplinary team will perform the ultrasound. In this case, the axial, coronal, and sagittal planes are assessed, and multiple biometries are measured, not only the basic ones performed in the basic central nervous system ultrasound. The objective of the neurosonography is to confirm the anomaly and counsel the parent, explaining the alteration, the different symptoms, and give them the information required to be able to make the decision on whether they want to continue with the pregnancy or not. The indications of neurosonography are listed below. The first one is related to history of central nervous system anomaly in the family. The second one is the most important one, and are the ones in which in the basic ultrasound an anomaly was detected. The third group are the extracranial anomalies, such as syndromes, and anomalies in which there is a risk of injury of the central nervous system. Let's see one by one. The first group is a familiar, personal history or alterations in a previous gestation. Regarding the extracranial anomalies, the most common ones associated to central nervous system anomalies are the facial anomalies, because the central organs are formed from the same origin. Cardiac rhabdomyomas due to the suspicion of tuberous sclerosis, genetic syndromes, or finding signs associated to genetic syndromes. As we mentioned before, one of the most important indications of neurosonography is finding an alteration in the central nervous system screening. In this list, you can see the different structures that are accessible, and the most common ones in which a patient is referred to neurosonography: ventriculomegaly, absence or anomaly of cavum septum pellucidum, increased sterna magna, and the presence of intracranial cysts in these proportions. The last group are those situations in which risk of brain injury, infections, stroke, or hypoxic ischemic phenomenon, twin-to-twin transfusion syndrome, selective IUGR, death of one fetus, ductus-dependent congenital heart disease, placental pathology, is an important group because the group with fetal growth under the 3rd centile is the one with more risk of neurological alterations. Other group is the one with patients with drug intake or toxics. Neurosonography. The systematic neurosonography is done by performing 3 basic scans in axial, coronal, and sagittal planes, in which the ultrasonography elaborates a mental 3D image of the different structures. Seeing them in different planes, we avoid the artifacts or images that don't correspond with reality, so we can establish the diagnosis. So the things required to perform a neurosonography are: know the neuroanatomy, know the embryology, and to have a normality curves of the different measurements. This is very important because the encephalic structures have a progressive development throughout the pregnancy and even after birth. Until 80% of the structures are completely developed before birth. There are 20% more that will continue to develop after birth. It is also important that there could be a false interpretation due to variants of normality, false alarms, subtle anomalies, or even transient or evolutive anomalies that with time can disappear or can be interpreted differently. Regarding the neuroanatomy, we have to take into account that there are 2 hemispheres that are connected through structures in the midline that are known as commissures structures. There is also the ventricular system. It is important to know well this system and the different alterations that could be found. So it is important to know the midline structures and in which moment are developed. Also to know the areas corresponding to the ventricular system. It is important to know the connections of the 3rd ventricle, between it and the lateral ventricle, and with the 4th ventricle, and the Sylvian aqueduct. Regarding the development of the central nervous system, it's important to know the chronology of the appearance of the different structures and the development of them. Know the trajectory of the different fissures to place the transducer in the optimal angle to assess them. Later on, I will comment how to perform this evaluation. Each structure has its own weeks of gestation in which we can start seeing them, and there is a gestational age in which this structure must be seen in any fetus. From the gestational age on, we can start to think there is an anomaly in the development of that structure. We have to take into account that the appearance has variations between one person and the other. For example, if we are assessing the vermis, 10 to 20% of fetuses have a visible vermis at 15 weeks of pregnancy. On the other hand, we must see it from 18 weeks in all the fetuses. The same happens with the corpus callosum. We should see it completely from 20 weeks of pregnancy, and is a structure that we cannot assess correctly before the 20 weeks. It is also important to have the normality curves depending on the gestational age and the normal variations. Note the parameters that correspond to measurements outside the normal range. For example, it is considered that a fetus has microcephaly when having a head circumference inferior to less than 3 standard deviations. In the case of corpus callosum measurement, we will use centiles. A small length of corpus callosum is considered below the 5th centile. In the systematic neurosonography and in the basic ultrasound as well, we start with an actual scan. It is important to perform a scan, so no area of the brain is left unseen. The list seen at the right are the structures that must be assessed during the evaluation. It's a slow scan, beginning at the most cranial part and descending until the fetal neck. We have looked at the cranium and the signs that could lead us to some of the pathologies. Look at this cranium form as a rugby ball. Identify the features and the integrity of all the bones, the symmetry, the cogenicity of both hemispheres. Taking into account in the proximal hemisphere, the cogenicity will be lower. See the structures regarding the circulation of the cerebral spinal fluid, the lateral ventricles, third and fourth ventricles, in front of the vermis, and identify the subarachnoidal space. After performing the actual scan, we should stop at the three sections in which we will identify the majority of the anomalies. If we take into account this sagittal view, we will see which are the structures that we are going to assess in the three basic sections: transventricular, transthalamic, and transcerebellar section. Here the same regarding the coronal plane. Transventricular section. If we go from front to back, we will see the interhemispheric fissure, corpus callosum sulcus, cavum septum pellucidum, third ventricle, the most posterior part of the corpus callosum, with its splenium, quadrigeminal, and ambiens cistern, and at the end, the interhemispheric fissure. At the sides, in the anterior part, we can identify the anterior horns of the lateral ventricles. In the middle part, the cavum vergae and parieto-occipital fissure, posterior horns and lateral ventricles, and the atrium. Let's now see the structures in which we should focus our attention. One of the most important parts of this section is the measurement of the lateral ventricles, to detect an alteration in the production, circulation, and reabsorption of the cerebral spinal fluid. The measurement should be made in this section, and we will have two guide signs to know we are measuring it correctly. ISWOG says we should locate cavum septum pellucidum and make the measurement where the choroid plexus ends, from on to on. If we take into account that what Joren and Bo say, we shall identify cavum septum pellucidum or fornix columns and place the measurement caliper where the parieto-occipital fissure is identified. It is important to see the proximal ventricle as well and see if they are symmetrical, although we do not measure them. Here we can see the differences between cavum septum pellucidum and fornix column. It is important to assess this correctly, because sometimes we are seeing the fornix columns and not the cavum septum pellucidum. And we could affirm this fetus has cavum septum pellucidum when in reality it hasn't. The main difference is that cavum septum pellucidum are seen as two lines with an echogenic space in between, and the fornix that corresponds with the base of the space called cavum septum pellucidum are two lines separated by a third line in between. In this video we can see well the differences between cavum septum pellucidum and inferior to it, the fornix. There are different types of normality variants regarding cavum septum pellucidum. In this case, we see a triangle cavum septum pellucidum. In this other case, we see these parallel lines more posterior and opened is due to the presence of cavum vergae, and that is continued with cavum septum pellucidum. In other case, we see an echogenic cavum septum pellucidum, and also sometimes we can find an echogenic center image that corresponds to cavum valley. This is sometimes reason to refer a patient to neurosonography, thinking it is an interhemispheric cyst, when in reality is cavum valley. Here we can see in detail the structures in the midline and the differences between what is normal and what is abnormal. We have a case of agenesis of corpus callosum with absence of cavum septum pellucidum. Here we see the callosum sulcus, cavum septum pellucidum, third ventricle, ambiens cistern, parietoccipital fissure, and at this point we find the splenion or corpus callosum. In this other image we see the absence of cavum septum pellucidum. We only see the fornix and the anomaly of the rest of the structures of the midline. This is a marker of anomaly of corpus callosum. The next section, descending caudally, is the one of the sections we learned at the beginning of our formation, because it's the one used to measure the biparietal diameter, head circumference, and with this too the cephalic index. Below 70% it is considered a dolichocephaly, and above 86% brachycephaly, rounder than it should be. In this section we will identify the interhemispheric fissure, the anterior horns of the lateral ventricles, fornix columns, thalamus, Sylvian aqueduct, this small structure found in front of the brainstem. It is important at this point identify the Sylvian fissure and see the variations throughout the pregnancy. Above it, we see a pulsed vessel that corresponds to the medial cerebral artery. In this clip, we can see the medial cerebral artery, a vessel passing at the level of the Sylvian fissure. Inferior to that section, we find this one, in which we can identify the fornix column, the third ventricle, which can also be measured with normality curves, Sylvian aqueducts, and the rest of the structures are the ones mentioned before. The last section is the transcerebellar plane, a little more oblique than the other two. From to back, we will identify cavum septum pellucidum, which is a reference to know we are making it correctly, the anterior horns of the lateral ventricles, Sylvian fissure. In the midline, the inferior part of the thalamus, fourth ventricle, vermis, tentorium, and here is where we perform the measurement of the posterior fossa, or cisterna magna, from on to on, from the most posterior part of the vermis till the most inferior part of the occipital bone. The measurements that should be done are the transversal diameter of the cerebellum, the anterior-posterior diameter of the cisterna magna, the symmetry of the two cerebellar hemispheres, the slightly increased echogenicity of the vermis, and the two septums, which are arachnoidal folds, or remains of Blake's sac. The difference between these two septums and the cyst is that these are symmetric, and we will always find it in the midline. We should always remember to assess the face in these three sections, the profile to see that the frontal bone is correct, the mouth and chin section, and the eyes section in the coronal plane and axial plane. In a coronal plane, we shall see the distance between both orbits, crystallines, and in the frontocoronal plane, we can see the nose, the superior and inferior lip, and the chin. We should assess the normality of all these structures. Till now, we have seen the characteristics and the different structures seen in the actual views. Let's continue with the structures in the sagittal and coronal view. Normally, these sections are done through a transvaginal access, but obviously, if the fetus is in bridge position, we will do it transabdominally. We rather use, if possible, the transvaginal access because the distance is not the same as and the resolution of the image is better with the transvaginal access. In a systematic way, the correct way to assess the coronal planes is by placing the interhemispheric fissure at 12 hours and see perfectly the symmetry between both hemispheres. In this case, we are seeing the scan, and then I will explain the different sections that should be assessed to identify the different structures. But always, the most important is to perform a slow scan without too much pressure so we do not deform the cranium. We have to see the homogeneity of the parenchyma, identify if there are cystic images that could make us think in hypoxic ischemic events or infection events, the size and form of the subarachnoidal space. See with detail the different structures in a coronal plane. We have 5 sections: the transfrontal section, caudate, thalamic, atrial, and cerebellar sections. In the frontal section, we will see the spheroids major vein, the interhemispheric fissure, the 2 anterior horns of the lateral ventricles, the echogenicity of the parenchyma, the sagittal sinus, and the orbits. Then we perform the transcaudate section. We see the interhemispheric sulcus as well, the anterior horns of the lateral ventricles, cavum septum pellucidum and its walls, the caudates, in which the germinal matrix is located, from which the neurons are formed and then migrate to the cortex. We can see the subarachnoid space, and in the midline superior to cavum septum pellucidum, we see the corpus callosum janum. It is important to confirm the presence of cavum septum pellucidum and that the anterior horns are not fusion. At the last level, we can find infection or hypoxic ischemic injuries. As I said before, here is where we have the germinal matrix, which is formed by small vessels, with an absent muscle layer, so very vulnerable to the insult. Here we have some more examples of this. Moving backwards, we see the transthalamic section. We can see perfectly the Sylvian fissure. It's easier to identify it in this plane than in the actual ones. We see the insula again. We see the cavum septum pellucidum, the anterior horns, corpus callosum body, and these are the ones correspond to the thalamus. In between both of them, we can find the third ventricle. Below it, optic chiasm. Also the interhemispheric fissure and the sagittal sinus. Then we have the transatrial section, which is not totally recognized, but can be used to measure the diameter of the lateral ventricles, especially the lateral ventricle that is less accessible from the axial planes. In this section, we can start to see the calcarine fissure, tentorium. We also start to see the cerebellar hemispheres. At last, we have the transcerebellar plane, in which we see the cerebellum, perfectly formed, the cerebellar sulcus, in the middle the vermis. Then we can see also the calcarine fissure, and the posterior horns of the lateral ventricles. interhemispheric sulcus. We should also assess the surface of the lateral ventricles, that there isn't any cyst or irregularities that could make us think of any infection, which apart from the germinal matrix is one of the most vulnerable parts of the brain. Now we will assess the sagittal planes, also preferably through transvaginal access, if the fetus is in cephalic position, but we can use the transabdominal access if the fetus is in bridge position. We will see the medial sagittal and parasagittal planes. This is the medial sagittal plane, because in this section we will see structures that have been in isolated sections, but that we should see them entirely in this section. This will be corpus callosum and cerebellar vermis. We will see all the parts of corpus callosum, genu, body, and splenium. We will see the anterior commissure and the posterior commissure, capum belli. We will see the different cisterns, apart from cisterna magna, the third ventricle, quadrigeminal plate, Monroe foramen, Sylvian aqueduct towards the fourth ventricle. Is one of the most important sections because there are structures that are only seen in this section. This is also the section where we make some measurements. Corpus callosum length, from on to on, from genu to splenium, assessing not only the length, but its appearance and the thickness. Also the characteristics of cavum septum pellucidum, which will be part in the anterior part and cavum vergae in the posterior part. We can also identify the cingulate sulcus. Regarding the posterior fossa, we will see the cerebellar vermis height and its anterior-posterior diameter. In occasions where there is doubt in its normality, we can measure the tegmentovermian angle from the most posterior part of the brainstem till the most anterior part of the cerebellum. In cases where it could be ascended or rotated, we also can assess the posterior fossa, the presence of cystic images, and the presence of bands. Regarding the vermis, we shall consider its echogenicity, the morphology, the fastigium, and the presence of commissures. In this section, we can also assess the vessels. It can be useful in cases in which there is suspicion of corpus callosum agenesis. The pericallosal artery can help to identify the trajectory and form of corpus callosum, and there is also the Galena vein. In the parasagittal plane, we can see the shape of the lateral ventricles and the characteristics of the periventricular and intraventricular space, and the characteristics of the choroid plexus, especially evaluable by the neonatologist. Also important to us is to see the presence or not of the synechiae or periventriculitis derived from infections such as cytomegalovirus. It is important, as I mentioned before, to have into account the variations in the appearance of the different sulcus. The Sylvian fissure is the first one that can be acknowledged from 18 weeks and shall always be seen at 23 weeks. And so it goes with the rest of the basic sulcus, such as the parieto-occipital, calcarine, cingulate, central, and temporal sulcus. Nevertheless, we have to take into account that we shouldn't be fundamentalist, because there are different versions depending on the author. And also, it is different when using MRI or ultrasound. With this slide, we can see the different gestational ages in which we can start to think there is a problem with the cortical development. We have to know that there could be individual variations. The Sylvian fissure can be seen in the axial and coronal sections. The parieto-occipital fissures can be seen in an axial section in the posterior part. In the sagittal and axial sections, convex sulcus, that start to appear at 27 weeks. These are the ones that should be assessed always in the basic scan. In the bottom of the slide, you can see the variations of the Sylvian fissure, the operculization. At the end, the approximation between the anterior and posterior edges till its closure around the 29 weeks. The calcarine fissure is found in the coronal planes, the cingulate sulcus in the sagittal planes. This one is especially clear to assess the normal development of the parieto-occipital and calcarine sulcus. At this point, we see this Y form that the two of them form. The superior one is the parieto-occipital and in the inferior the calcarine. And this image is well seen in the middle sagittal plane. Here we can see the fissure's development and the normality of its formation. At 18 weeks, this triangle form that becomes more angulated to end around 30 weeks in Y form or with a circle anechoic ending. It is also important to identify the indemnity of the skin, that there isn't any structure outside the skin, the vertebral columns as two parallel lines, with a slight elevation at the sacrum. The anterior lines correspond to the vertebral bodies, and the most posterior ones to the lateral process. This confirms the normality of the vertebral column. We should complete the evaluation with a coronal scan and axial scan. In the coronal scan, the middle line corresponds to the vertebral bodies, and the lateral ones corresponds to the lateral processes. In this case, they converge at the sacrum. It should claim our attention a dilation of the lateral process. We can also suspect the presence of hemivertebras or scoliosis. Then, we end with the axial plane, with the spine anterior. Here we can see perfectly the closure of the medullary canal with the lateral process. We also see the vertebral canal that has different morphology descending on the level of exploration. We have to confirm the indemnity of the skin and the vertebral muscles and the presence of the medulla. We know that there is sometimes difficulties in detecting the closed defects of the neural tube, and it could be helpful to identify the medullar cone. It is located usually between L3 and L4 at 22 weeks. We can identify it as a triangle anechoic structure inside the medullar canal. We must suspect a closed spina bifida when it is in an inferior position. And this is all.